So I'm going to talk about the drugs patients are on after an acute coronary syndrome. So, I mean, nowadays when a patient has a heart attack, they arrive in hospital, they're often in hospital for 2 or 3 days. It's a real whirlwind. They may come into hospital medication naive, or they're on a collection of pills, and then suddenly in hospital everything has changed, and then they're sent home. They may not have time to ask why things have changed. Part of the recovery from a heart attack process involves cardiac rehab. And during the cardiac rehab sessions, we have sessions where the pharmacist and a cardiologist will talk to the patient. We go over the rationale for being on medication, explain why things have changed. Often patients will get a follow-up 6, 8 weeks post-discharge, and from a hospital viewpoint, that may be it. So the patients return to you guys to be looked after, and then the questions start appearing. They don't always pop up early on. And, you know, when you're 50, 60, do you want to be on pills for the rest of your life? You get side effects. Why am I on all these things? And really, there's 3 key points which are in my last slide. So if you want to switch off for 10 or 15 minutes, that's cool. I'll tell you when the last slide's coming up, but there are 3 key points there. So we've got a couple of cases. 67-year-old diabetic, hypertensive. She's got a prior history of an MI. She's had an acute coronary syndrome with heart failure. She's got LV impairment, gets a bypass, and has got a creatinine that is mildly elevated with microalbuminuria. And as you can see, medication-wise, she's on dual antiplatelet therapy, like Will said. That's going to be for at least a year post-ACS, still on metformin, but a statin has been changed. And I'll quickly brush on that. Essentially, the reason she's had a simvastatin bumped up to atorvastatin is for more potency, and I'm sure Chris will be talking about that. And the felodipine and benjoflurazide have disappeared, and she's now on an ACE inhibitor, beta blocker, and spironolactone. Just a quick word about thiazides. I mean, post-MI, we want to try and avoid hypokalemia because it's associated with an increased risk of arrhythmias. So we try and avoid using thiazides as antihypertensives in patients like this. Often, you know, with her being on an ACE inhibitor, the risk of hypokalemia is lower, but as a monotherapy, it's something we'd try and avoid. And obviously, she's a bit frustrated. The doctors in the hospital tinkered with her pills. She was happy on the old ones, but wants to go back on them and try and cut back her pill number. And the second case, I guess, is the other extreme. It's a guy who's completely fit and well. He rocks up, he has an acute coronary syndrome. He's got single vessel disease. He has a stent put in, his cholesterol's a bit high, HbA1c is good, blood pressure's normal, and he's gone home on the usual combination. As is not uncommon, he's developed a degree of erectile dysfunction. He's a bit dizzy when he stands up. And when he's out with his cycling group, he just can't keep up with people he used to be able to. And he wants to know, he knows why he's on the pills, but wants to know if he can cut back and how would we go on. So what I'd ask the patient is, you know, why do you want to stop the pills? Is it because you got side effects? Do you understand what they're for? Do you just not like taking medication? And we know that a decent chunk of patients just stop their pills. And part of that is, do you understand why you're on the pills? What impact they're going to have on how you feel? And most importantly, how long you live, because ultimately all of us just want to be on pills that make us live longer and live well. And what do I ask myself? I ask myself, why is the patient on the pills again? Same as the patient's asking. But when I'm thinking, have they got any symptoms? In an asymptomatic individual, that may be where you can cut things back. If they've got side effects, obviously you want to change things. You're looking at their comorbidities, and especially from after an MI, you're thinking diabetic, renal impairment, if they've got proteinuria, do they have hypertension? Are there other indications for carrying on their medication? One of the key questions is, what's their cardiac function like? If you have a heart that works well, generally you're going to live well. If your heart doesn't work very well, that's going to impact on how long you live. So taking medications to try and improve heart function and keep you alive is really, really important. We want to know what was done to the heart. Like I said, in the case of Dave, he had 1 coronary stenosis. That was treated with a stent. As Will said, he'll get a great result. His stent will stay good. He's going to be able to get back to normal life, and we'd expect him to be asymptomatic. For the first case, she'll have had multivessel disease. She's had bypassing. And the question we ask as cardiologists, has every narrowing been treated that could be treated? Bypass probably has done that. Stenting generally will, but not always. And if there's narrowings that are untreated, they may cause symptoms, so the need for medication is going to be a bit higher. So a quick reminder, you know all this. What happens when a heart attack happens? A blood vessel blocks off suddenly. From the moment that blood vessel blocks, heart muscle starts to die. And that's why it's so uncomfortable for the patient, or they get pulmonary edema or whatever. The key treatment is picking that up, getting to hospital, getting your blood vessel reopened. And nowadays that involves going to the cath lab. Generally that's open 24 hours a day, and guys like Will sort of are beavering away day and night to try and reopen heart blood vessels. And why do you reopen a heart blood vessel? It saves heart muscle. So as soon as you open a vessel, the flow improves, and hopefully you reduce the size of the heart attack. But it should just be noted, not everyone who has their blood vessel reopened is actually going to save heart muscle, because of something called microvascular injury. So all the gubbins that's in the vessel gets washed downstream and blocks small blood vessels, so you can still get heart failure or LV dysfunction even if you had a blood vessel that's open. That's the key thing about identifying MIs early. Now, if you kill heart muscle early on, that's not too much of a problem. But as time passes, I'm sure you will remember the ventricle is like a bullet. It's a geometrically really sound thing to generate force. If you kill one area of that, the transmission of force is no longer symmetrical, and where the infarct is, it will slowly start to expand. And that's what's shown up in this picture here. You know, the infarct's at the apex and it's expanding. And over time, the heart gradually changes shape. The rest of the heart changes. The heart gets bigger and starts not working so well as a pump. And that's the procedure called, the process called remodeling. And that's what medications are trying to protect against. And so what can we do to help delay that happening? That's where ACE inhibitors come in, beta blockers and aldosterone receptor antagonists. And if you have cardiac dysfunction, generally you're going to be on all three of those drugs, and they're just blocking kind of the negative effects that an MI has on a heart at different places. So what do ACE inhibitors do? They reduce the LV remodeling process. This is all stuff I think everyone knows about this. This all came out in the 90s. And what we have to remember, that's before people went to the cath lab. Those of you that were working in the 90s will remember what happened was that's when thrombolysis appeared on the scene. And before that, people used to just get treated with aspirin. But the ACE inhibitors were shown to reduce sudden death and reduce the risk of LV remodeling. They also help protect people against getting symptoms of heart failure and experiencing a cardiac death. And if you look at these two graphs, this one, just to prove, I was still at medical school then. You've got placebo and captopril, so an old school drug. And captopril reduced mortality. But if you look at this, the interesting thing is, you know, if you go out to 4 years, the risk of death was still around 20% if you're on an ACE inhibitor. Even at a year, the risk was 10%. This is more contemporary stuff using an angiotensin receptor blocker. And you can see how the mortality has dropped to 1 or 2% at a year. That's the impact of intervention and the other medications we have available. But ACE inhibitors are still an important part of treatment. When are they started? They're started early. Generally, we try and start them within 24 hours. You start low and want to get the dose up. But essentially, we'd prefer that everyone carries on an ACE inhibitor if possible, especially if they've got LV impairment. And does it matter which ACE inhibitor? I mean, we're going to come back to people with good LV function being on ACE inhibitors forever, but not all ACE inhibitors are equal. The ones that have been shown to have a wee bit more benefit are things like perindopril and ramipril. And perindopril is actually available here, and I'll just say, certainly at Middlemore, we're moving towards using perindopril rather than cilazapril. Cilazapril doesn't have a lot of evidence behind it in heart failure or in post-MI, basically. Perindopril is widely prescribed globally, but cilazapril has actually got a niche market in New Zealand. So we're trying to switch our patients. Any of you see patients discharged from Middlemore, that's why we're making that shift to perindopril now. It's funded. It's simply because of availability, and I'm sure you all know patients rock up and say, pharmacist changed my drug, they've run out. That happens with beta blockers, so we're trying to switch to bisoprolol more than metoprolol, and like I say, there's a risk that one day cilazapril may disappear. Does it matter whether it's an ACE inhibitor or an ARB? In essence, this graph just shows no, there's equivalency between the two. It's just important to be on one of those. So who should be on an ACE inhibitor? If we look at guidelines from America, guidelines from Europe, all diabetics who have an MI, coronary disease, should be on an ACE inhibitor. Anyone who's got hypertension, you should try and get them on an ACE inhibitor. If the ejection fraction is under 40% or they have a clinical heart failure syndrome, they should be on an ACE inhibitor. If it's an anterior MI, they should be on an ACE inhibitor. If they've had a prior MI, if they've got renal impairment, proteinuria. So essentially everyone who has an MI should be on an ACE inhibitor. When you look at the data from the ANZAC's QI, which is a database looking at the New Zealand population, about 80 to 85% of people who have an MI have an indication to be on an ACE inhibitor. And the guidelines that are just coming out this year from the Heart Foundation in New Zealand is that any patient who has an MI should be on an ACE inhibitor, and they should be on an ACE inhibitor for life. That's going to be a small percentage of people who don't have one of the above, but most of them will. And also there's a push towards preventative therapy with ACE inhibitors as well, because they do reduce the risk of further vascular events. Beta blockers. Beta blockers probably the most important drugs to be on if you've got LV impairment. In the early days, once again in the 80s and 90s, we used to give IV atenolol when patients came to hospital with an MI, and that was to reduce the risk of cardiac rupture. It always used to get my heart racing when we were giving it, because often patients crashed. And it reduced the risk of arrhythmias and recurrent ischemia. And there's been a lot of toing and froing about beta blocker use after MIs, how long should they be carried on for. Essentially, anyone who has LV impairment, so an ejection fraction under 40%, and probably if they have an EF between 40 and 50, looking at stuff from ANZAC's QI, they should carry on a beta blocker indefinitely. They help prevent LV remodeling, or at least delay it. They have a survival benefit in terms of reducing the risk of ventricular arrhythmias. But if you have normal LV function, you have no symptoms, it's recommended that a year you can withdraw a beta blocker. So it's one medication, that's a slight change, that's in the new guidelines. The beta blocker is no longer for life, which is usually a good thing for patients. Because of all the drugs we give people, these tend to be the ones they complain about the most. Moving on to aldosterone receptor antagonists, which used to just mean spironolactone. Once again, who do we give these to? People with LV impairment. It was shown that EF under 40%. If people have had heart failure as part of their acute coronary syndrome, or if they've got diabetes and a poor LV function, they got benefit from being on an aldosterone receptor antagonist called eplerenone. And once again, it reduces mortality and reduces heart failure presentation. Now, the important thing I would say with anyone on a drug that's modified, I'm going to call them ARAs, along with an ACE inhibitor, it's important to check their potassium every 3 months or so. Hyperkalemia is quite literally the killer if you're on an ACE inhibitor and spironolactone. It's preventable by monitoring, and all the trials suggest that that your electrolytes be checked every 3 months. And as I'm sure you're all aware, spironolactone causes gynecomastia, and it happens in about 10 or 15% of patients. It doesn't necessarily happen within the first year or two, it may be 5 or 10 years down the line. And that's where the drug that's used in the trial post-MI, eplerenone, has recently become available. So the availability of this is a positive thing. So for those of you that went to sleep for the last 10 minutes, these are the key facts. ACE inhibitors for everyone. So anyone who has an acute coronary syndrome should be on an ACE inhibitor, provided there's no side effects. Beta blockers, you can carry them on for a year, and if LV function is good, the patient's got no symptoms, no residual ischemia, it can be stopped. Generally, I withdraw them gradually over 3 to 4 weeks to prevent the rebound tachycardia. If there's LV impairment, the beta blockers for life. Aldosterone receptor antagonists, if you're on one, you should carry on with it for life, basically. So those would be my key points with the drugs. And if a patient's on amiodarone, always ask why. Because it's a noxious drug. Generally, we don't carry it on longer term after an MI. And if, just a quick reminder, if someone has been on amiodarone, up to 2 years post cessation of the drug, they can get thyroid dysfunction, so it's really important to monitor thyroid function tests. If you pick up thyrotoxicosis early, usually it's easier to treat than when it's clinically apparent. So if we come back to our cases, you can see Jane's got multiple indications to be on her perindopril. She's a diabetic with renal impairment, proteinuria, coronary disease, LV impairment. Bisoprolol, she's got LV impairment. And has had heart failure, and ditto with the spironolactone. So I would just discuss the reasons why she's on the pills. These are to keep her feeling well, to help her live well, and to keep her alive. The older medications she was on weren't doing that. And just with discussion, hopefully she'll buy into that. The ticagrelor will be able to stop at a year. With Dave, our cyclist, as I said, the bisoprolol could be withdrawn at a year. The cilazapril, if he's getting postural hypotensive symptoms after the bisoprolol has been withdrawn, personally I would stop it. I don't think the benefit of ACE inhibitors post-ACS is huge in someone like this. I guess the other thing for him is that he had the erectile dysfunction. That may be a side effect of the beta blocker. We know that patients who have coronary disease often get erectile dysfunction independent of the medications we give, but he can safely use sildenafil or something like that as well because he's got a good effort tolerance. Oh, this is a good question. So if you have recovery of ejection fraction, can you stop a beta blocker if it's causing side effects? My answer to that would be yes. When people have a heart attack, the heart muscle takes a hit, so it's stunned. With reperfusion, like we talked about, it reestablishes flow. If the heart recovers back to normal, so we're saying an ejection fraction in the 50s, then yeah, I believe you could stop the beta blocker because you've achieved the therapeutic effect you want. Definitely, if it's below 40, it needs to be carried on. 40 to 50, as I say, it's a question we're sort of looking at the moment. Any choice between felodipine and amlodipine? Personally, I'd say amlodipine's a wee bit better. Well, what dose of perindopril? I think the maximum dose is 8 milligrams. It's interesting, in the hospital, we start on 1 milligram and the pharmacists have started complaining because the perindopril is a little tiny pill and it's tricky to cut in half. And you know, when you start cilazapril, you start 0.5, which is a tenth of the maximum dose. But the perindopril, it actually looks like you start 2, which is a quarter. I don't know why we use such small doses, but usually hypotension's not an issue. But that's the dose you aim for is 8 milligrams. Cool.